Okay, good morning again. We will go ahead and get started. Emily, if you want to do the housekeeping.
Good morning, everyone. My name is Emily Field, and I am an evaluator at USET Tech. If you haven't done so already, I'm going to invite you to mute yourselves, and please don't take offense if I mute you. Please share your name, affiliation, title, and email in the chat box if this is your first time attending. Enter any questions you have throughout the presentations into the chat, and we'll get to them towards the end of the presentations. We are recording this session, and towards the end of this call, I'm going to share an evaluation survey link in the chat. If it's hyperlinked, please click it. If it's not, please just copy and paste it. It's just 5 really quick questions to get feedback on how we can make these calls more beneficial for you and your tribal nation. And if you are on the phone and would like presentations and are not already on the email list, my email is efield, that's EFIELD @usetinc.org. If you send me an email, I will make sure you get added to our contact list. And that is all I have.
Great, thank you. Next, we'll have Taloa Berg do the staff introductions for those that are presenting today.
Good morning, everyone. So first up, we have Christy, and she's going to give us the usual updates for the IH area as far as testing goes. And then we'll head to Dr. Mehra for his updates on COVID. And finally, our special guest, Dr. Patterson, will talk to us about mental health in times of a pandemic. So I'll go ahead and pull up Christy's presentation now.
Hello, everybody. It's good to see you all again. Thank you, Taloa. I appreciate it. So I'm just going to go over the numbers like I do every week, reporting what we're seeing in our area in terms of COVID. For those tribes, and there are 26 tribal nations who are reporting to IHS their testing numbers, we can see that this week there were 5,484 tests performed, and that's up from 4,669 last week. We have an extra 127 positive tests. It was 650 last week, and it's up to 777 this week. And you can also see the negative tests are up as well. It was 3,880 last week, and it's 4,302 this week. So we are seeing an increase in numbers, and we are seeing an increase in testing, which we're glad to see. Go ahead and go to the next slide, Taloa, please. The next slide shows the rates, the cumulative incidence rates of COVID-19 amongst all people in the USET CHISDA, so all the counties that make up the tribal CHISDAs in our area, the 13 states in which USET has tribal nations and the United States. And you can see that of you states as well. Right now, for the U.S. of $6,000. So our thing.
Okay, I believe that Christy froze. So we'll move on to Dr. Mehra for his updates.
I lost my connection. My apologies, y'all. That's really all I had to say is we are expecting the rates to increase in the coming weeks. It does look like we are increasing somewhat quicker than the US rate, so that is not encouraging to me, but we will continue to monitor. As always, keep the following questions in mind. Go ahead and go to the next slide, Taloa. Just the things that we can do to better support you. We got some really great feedback from last week that gives us some ideas for next ECHO presentations. As always, we hope that you fill out the survey. If you have additional thoughts that you would like to share, you can email those to Emily, and she just shared her email address. And with that said, I'll go ahead and turn it over to Dr. Mehra for his updates. Thank you.
Okay, thank you, Christy. So I will update on a couple of things that I think are relevant, and I always can be wrong about that. There's so much new information coming up every day. It's difficult to tease out what is going to be really important or not. So this is the best I could do this week. So a little bit about close contact definitions have changed. Symptoms have been updated by CDC. I will focus more on do we test or don't we, should we test or not those individuals who have COVID, have completed their 10 days, are asymptomatic, and they need to go back to work. Discuss a little bit of what is the evidence of not testing them, and a few updates on treatment. So the CDC basically has improved the precision in which they define a close contact by adding the duration component. So close contact is if you are exposed to someone who has COVID, who's COVID positive, you are considered a close contact if the exposure occurred within 6 feet of that person, and the duration of the exposure has to be more than 15 minutes. And also you were not wearing PPE. That's important for healthcare providers, because if you're using a mask, surgical mask and goggles, or a face shield, you're not a close contact. You were really not exposed because you were wearing your PPE. So the CDC added the 15 minutes. We were using 10, but I just want to clarify that this 15-minute is not based on any study. I think it's just their expert recommendation and common sense. So this may change in the future if we have information that a lesser duration could be a problem. The other important thing is that a cloth face covering is not considered PPE. So despite the fact that it is recommended for the general population, this is not the face covering that's recommended for healthcare workers. So a healthcare worker needs to have at least a surgical mask and goggles when they're in the presence of a COVID positive patient to not get infected. The other change was the temperature when you're screening for symptoms. We at Cherokee Nation were using 99.6. That was based on the initial data that came from China, that 40% of the individuals, their temperature was 99.6 or higher. Not everybody had high temperatures, but CDC came up with this 100 cutoff. I think it's good because we are seeing a lot of patients that they come in, or healthcare people that come into the facility. You measure a 99.6, that's their only abnormality. Takes a big workup, and we haven't seen anybody yet who's been COVID positive with that isolated measurement. So this will increase the threshold for detecting it as the sole symptom. And of course, remember that people could have normal temperature and still have COVID, especially if they're elderly, if they're taking NSAIDs, or they're immune compromised. So at the end of the day, it's your clinical judgment which will decide if you test someone or not. But at least for objective parameters, this is the one that's out there. So this is the new set of symptoms. So we have screeners in our doors, and they ask everybody who comes in, do you have fever or chills, a cough, shortness of breath, fatigue, muscle or body aches, headache, new loss of taste or smell, etc. And if any of these are positive, then they're sent to the COVID clinic for evaluation, basically testing and making sure that they don't have any other problems. The symptoms that were incorporated were nausea, vomiting, and diarrhea. They were not there before. And I was surprised that they were not there because there's a lot of reports that 20 or 30% of the patients have GI symptoms. And I think they brought back headache and introduced fatigue, I believe. Those are the new things. But one point I really want to emphasize is that 95% of patients with COVID-19-like symptoms do not have COVID-19 and need to be evaluated for other conditions. So one mistake that I see too often is a patient comes in, let's say with fever and a headache, they swab them for COVID and send them home. And then they're telling you don't have COVID. Yeah, but they still have a fever and a headache. So what is the cause of that fever and the headache? So providers should be cognizant that, of course, they need to rule out COVID, but address the symptoms to see if they need to do something else. For example, if someone comes with diarrhea, they could have salmonella diarrhea for all I know. And not only test for COVID, but make sure that you address that symptom like you would have pre-COVID pandemic. They also updated and simplified, which this is good, the guidance for exposure at your workplace with your healthcare personnel. So basically it boils down to if a healthcare worker has had prolonged contact, and prolonged is defined now as 15 minutes, with anybody who has COVID-19 and the provider or the healthcare person was not wearing a respirator or a face mask, was not wearing eye protection, and here actually cloth face should not be there. That's a mistake that the CDC made. I didn't make it. And that then they should be considered an exposure and be sent home for 14 days. If the healthcare worker was not wearing an N95, the full equipment, N95, gown, gloves, etc., in the presence of a situation where there were aerosols being generated on a COVID positive patient, then they should be quarantined also. So for example, if I'm a provider and I'm in a patient's room and I'm not wearing, my surgical mask and eye goggles, I'm fine. But if they were nebulizing that patient and he's COVID positive, I should have had an N95 on. If I did not have an N95 and I was there for more than 15 minutes, so on and so forth, I should be sent home and quarantined for 14 days. So that's the recommendation. Before it was like a table with 20 options and it was daunting just to go through the whole thing. I think this simplifies it. The only thing I'm seeing now, oh, okay, I'm sorry. It was my mistake in the interpretation. It says healthcare provider not wearing eye protection if the person with COVID-19 was not wearing a cloth face covering or face mask. Okay, so if the patient is wearing a face mask or a face covering, if you don't have eye protection, that's okay. But if they were not wearing that, you should have had eye protection and you would be quarantined. All right. Okay, so to test or not to test? That is the question. So the CDC has guidance on when someone has COVID-19, they're put in isolation, and then they can be taken out of isolation based on two strategies, a symptom-based strategy or a test-based strategy. So the symptom-based strategy is that the patient has had at least 3 days of resolution of their symptoms and at least 10 days since the symptoms first initiated. If they meet that criteria, according to CDC, they can be sent home and they're fine, or to work. I mean, not home. They can go back to work or to the regular environment. But the other option is the test-based strategy, which requires 2 consecutive tests that are negative to return that patient to work. So the problem that we were facing is that many healthcare workers had COVID-19, and then they were fine. They came for testing. We tested them, and one of the tests was positive. Then we said, have them come back in 5 days or 7 days. Test them again, and the test was positive. We had healthcare workers up to 30 days being positive for COVID, and they were feeling great, but we didn't get them back to work because we had the test-based strategy. So our concern was, okay, CDC is giving two options. We're using the test because we want to be cautious because we don't know, there's not enough data out there. But now I think we have more data, and that's what I'm going to present. And that is what made us switch to a symptom-based strategy from a test-based strategy. So this is a South Korea CDC, and what they did was very interesting. They had 447 patients who had tested positive for SARS-CoV-2. And that tested positive after they were discharged from isolations. Like these patients were sick, then they got better. On day 10, they said, you're fine, you can go home, or go back to work, whatever. And then for whatever reason, they got tested again, and they were positive. And the reason on which 285 of these 447 got tested, almost 60% because that was part of their protocol, they were screening, and 37% because they came back with symptoms, and they were retesting them to see if that symptom was COVID or not, or what was it. So what the CDC of South Korea did is they did contact tracing on these 285 cases with the assumption or the hypothesis that if they are infectious, they should have their close contacts, some of them should have gotten infected, right? So they followed 790 contacts of these individuals who, after 10 days, still had a positive COVID test. 350 were household, and 439 were non-family members. So what did they find? Oh, here on the right, there's a chart that just shows you what is the chance in their scenario of having a positive COVID test after you're discharged from isolation. And it goes from 48% if you're being discharged, or if you had it in a nursing home, or it can be as low as 12% if this is school staff that had been tested positive for COVID and got sick with COVID. So that varies on the population that you're seeing. So this graphs just show you of the 226 patients that were discharged, how many days after the initial symptoms they still had a positive COVID test. And it could be as long as 82 days. Now, the majority were around 40-something days. So it was 44.9 days, the average the average day that they would test positive after discharge. Now, testing positive discharge from isolation, not from symptom onset, but after you were discharged, how many days after discharge did they test positive? And the majority were within 1 or 2 weeks tested positive after discharge, but there were people that 37 days after discharge were testing positive. And we've had personally a case that has 32 days after their 10 days were met, 32 days later, they were still testing positive. So what are the findings? Of the 790 patients that there were contacts to those 285 re-positive cases, there were no new cases of COVID-19. So they could not find anybody infected by this cohort of re-positive patients. They did viral cultures on 108 of those re-positive cases, and they could not isolate a virus in a single patient. And on the 23 patients who they had some serology available to test, some serum samples to test, 96 revealed neutralizing antibodies, 96%. So from this very interesting study, and it's probably the best study so far, it tells us that if you test positive after you've been discharged from isolation by the symptom-based strategy, you're not going to infect anybody, at least based on their data. And that in 108 patients, the virus was not able to be cultured, so it was not an infection. So that PCR is positive, but it's not reflecting a viable virus. And on this very small sample that they could see if these patients would be immune, 96% had neutralizing antibodies. So it's possible that the infection does give you immunity, at least for a certain period of time. We don't know if it's going to be immunity for 6 months or for 12 months or whatever. I'm sorry. So after this study, we at Cherokee Nation changed our policy and we're not doing a test-based strategy to discharge patients back to work after they completed their 10 days since first symptoms started. We're using the symptom-based strategy. Now, we are running into a situation in which a person comes in and their employer is requesting a COVID negative test for them to come back. Well, I don't know where they're getting their information or their policy, but we will offer that to the patient, not to put, the patient's in the middle of the battle, so we don't want them to struggle. So we'll do a COVID test and they'll give them the report and they can take it back. Now, if the test is positive, I don't know what the employer is going to do, but we would not do anything. Okay, one important thing, the recommendation is just to be on the safe side until we have more data. You can go back to work, but we recommend wearing a mask and social and physical distancing for 14 days after they return to work. Which in our facility, that's not an issue because that's basically what everybody has to do. But someone might work in a place in which those norms are not being implemented, and we recommend that. Okay, so I'm sorry, I'm a little bit, my hand is a little bit shaky today and I'm clicking when I'm not supposed to be clicking. So there was a little bit more data on loss of smell and taste in COVID-19 patients. So I think I presented to you maybe a month ago a study in which these symptoms persisted for over 6 months of many patients. This is a European cohort, over 2,000 patients. They had a questionnaire asking them for these symptoms, and 87% reported experiencing loss of smell. And many happened when they got infected with COVID. A subset of 90 patients went objective olfactory testing, and it confirmed the smell dysfunction in 60% of these patients. Interestingly, the loss of smell was not associated with nasal obstruction, rhinorrhea, or postnasal drip, which would be something you would expect in anybody who has a viral infection and has these symptoms. So it is a very specific effect of the virus or in your sensory pathways of your smell and taste. 1/3 of the patients recovered their sense of smell by the time of the questionnaire, and loss of smell and taste lasted at an average of 8 days. So this was a little bit surprising to me because the other study I had read was this had persisted for many, many months after the infection. So, it might be a different population study, different methods of studying them. But it is a little bit reassuring that maybe this is not such a big problem on the long term. But it is extremely frequent when the patients have the acute infection. By no means is this specific to COVID. Some other viruses do cause these problems, but it seems to be very common in COVID. Okay, remdesivir trials. There's a little bit of an update here. So remdesivir is the antiviral drug, the only one that's been approved for treatment by the FDA, but still it's under emergency use approval. It is still being investigated. And over 1,000 patients that were hospitalized with COVID-19 were randomized to receive their 10 days of remdesivir placebo. And what they noticed is that the patients who got the antiviral recovered sooner than the patients who did not. And although there was a difference in mortality, it was not statistically significant. But there was a trend that patients who got the antiviral did a little bit better, but that's not fully confirmed. So in this graph on the right, you will see on the red line is placebo, the blue line is remdesivir, the shaded area is the confidence interval limits, and the different graphs are the different subsets of the population. So the first graph is overall, the second graph is patients that did not receive oxygen. This graph C is patients who received oxygen. Graph D is patients who received non-invasive ventilation, like BiPAP, for example, or high-flow oxygen. And graph E is the ones who were on a vent or ECMO, the more serious ones. Now, when these lines and shaded areas separate, that means that the antiviral has an impact on these patients. And as you can see, the only place where it clearly separates is on patients receiving oxygen, but not so much on the ones who are sicker, this is what's puzzling to me, it's not so much on the ones who are admitted to the hospital but do not need oxygen. I would expect this to be better because the thought process is this. For most antivirals and respiratory infections that we use, the earlier we start the antiviral, the better it is and the effect that you have. The example is influenza. You have to start oseltamivir within 48 hours of the symptom initiation, or it doesn't work. Here we're starting like several days after the symptom initiation, but it apparently works well in patients who are receiving oxygen, and we don't know the impact on the other ones. So this is a study that compared 5 days versus 10 days of remdesivir. And if you look at where I'm pointing with the arrow, the patients with ambient air or low flow oxygen, there really doesn't seem to be a difference when you look at the light blue shaded part of the columns. There's really not a big difference if you give 5 days or 10 days, and this represents patients who were discharged from the hospital, meaning they're well, right? If you're discharged, okay, you can be discharged alive or dead. These are discharged alive. They're doing well. But when you look at the graph here, the columns on the left, the ones who were on invasive mechanical ventilation, it appears that the ones who received 10 days of treatment, more of these patients got discharged home than the ones that received 5 days of treatment. So the recommendation is, if you have a patient that you hospitalized and has required oxygen, but not invasive ventilation, 5 days probably will cut it. But if the patient is on a vent, if it works, and this is an if it works, it probably needs to be 10 days of therapy and not 5 days. Now, the major news that came out this week was that they proved that the antiviral has a benefit on individuals who have pneumonia, who are admitted to the hospital and do not require oxygen. So this is like milder forms, but individuals at day 11 had higher proportion of patients who achieved improvement than the individuals who did not get remdesivir. So also they saw a difference in mortality, but it was not statistically significant. So the bottom line is, in our facility, and interestingly enough, since this change, we've had 3 patients on remdesivir. IHS is providing through a donation from Gilead the antiviral for us through Oklahoma City. And we have actually 3 patients in the hospital right now on remdesivir. All of them came in with pneumonias. None of them were hypoxic. 2 unfortunately became hypoxic during treatment. But they're well. So cross your fingers, they'll do fine. So this is a nice cheat sheet. I have a problem with my English pronouncing that. So if I say something wrong, please forgive me. This is from Emory University. This is not updated to I'm sure they have updated it on their website, to the last Monday news that I just told you, pneumonia without oxygen requirements can use remdesivir. But it summarizes very nicely the data from remdesivir and COVID-19. So if you want to download it and keep it handy, it's pretty useful. Okay, and finally, last but not least, another study that basically shows that hydroxychloroquine not only is not good, but it has higher mortality rates than the control group. And these are 15,000 hospitalized patients in which hydroxychloroquine was given with or without a second generation, with azithromycin. Now, this was not a randomized study. This is a registry. So we're still waiting for the randomized studies, but the few that are coming out with some preliminary information are not very positive, meaning it doesn't seem that this works. There was one study that came out last week in which individuals got hydroxychloroquine to see if they could prevent the infection. That was randomized, and it did not show any differences in infection prevention. And that's it. Thank you.
Thank you, Dr. Mehra. Does anybody have any questions for Dr. Mehra at this point? If not, we'll move on to Dr. Patterson.
Okay. Hello, everyone. I am going to try to share my screen here and see if we can't get this going. There we go. Okay, can everybody see that okay? If you have any questions as I go along or you have any comments, this isn't an exceptionally long presentation, maybe 20 minutes or so. And so feel free to chime in if you have any questions. And thank you for asking me to do this. When Danielle contacted me about doing this, she sent me some information about some of the concerns that many of the people in the clinics are having. And so I wanted to address some of that. I wanted to talk about some of the results with what we're seeing in the community, how it's affecting healthcare workers, what's going on, and how to maybe take better care of ourselves and encourage the clients that are being seen to take on different ways to take care of themselves. So some of the things that has been coming through as far as mental health concerns and health related co-occurring mental health concerns in the community, we have during this COVID pandemic seen an increase in depression and depressive symptoms. There's an increase in anxiety and related symptoms, and I know this is not surprising to y'all. You're probably seeing this. There's an increase in prescribing psychiatric medications during this time. It's also triggering PTSD symptoms for a lot of people, and some of that is because of the isolation. There's also been a documented increase in attempted and completed suicides during this time, again, because of the isolation and the loneliness and depression that is triggered. Increase in domestic violence. I don't know how much you have been seeing of that, but I have talked to some of the people some of my colleagues that work in probation and in the courts, and right off the bat, early on in the first couple of weeks, they were seeing an increase in domestic violence cases coming in. And we'll touch on that just a little bit. Naturally, during times like this, during this time and during times of crisis, an increase in alcohol and other drug misuse, an increase in substance use disorder relapse, and an increase in overdoses and deaths by overdoses, and worsening of chronic health problems due to increased depression. All of this. I was just reading an article earlier this morning verifying that during this time it's kind of spotty among different states, but there's several states in particular that have an increase in opioid overdoses that are non-fatal and also fatal overdoses from opioid use. So looking at just drinking during the pandemic, and I know on many of the reservations and in the clinics, you see a lot of problem drinking due to the high rate of alcohol addiction in the Native community. And so there are people that are teleworking may be more likely to drink on the job, and people are doing surveys And people are admitting that when they're at home working, they are drinking more. Specifically, beer is the drink of choice. A third of U.S. workers believe they are drinking more during this time. And there's been a 10% increase in calls to the American addiction centers for asking for help, needing treatment. And in March, according to the Substance Abuse and Mental Health Services Administration, there was a 58% increase on alcohol sales all over the United States. 58% increase. And online orders of alcohol increased 300% in March. So that in and of itself tells you that there's an increase in drinking behaviors. When we look at domestic violence, we can look at why would it increase during this time? And I think some of it's common sense, but stress is increasing, and stress, just the unknown, fears of the unknown, stress about managing home and financial insecurity. There's not really an outlet for frustration. So before, when someone got angry, they could go out and go to a friend's house or go to the bar or wherever they were going to go, and that outlet was taken away. And then more time being spent together at home, that there's not a way to get away from each other. So encouraging people, if you know that they're in these types of situations, encourage them, remind them of those coping skills. Go take a walk outside to get away, to get out of that confinement. Participate, find fun activities that they can do as a family or they can do together at home. Engage in prayer or spiritual activities, and create a safety plan on both sides to try to prevent a violent situation. And some things to expect, that I know that you've probably already been seeing some of these things, but just to expect is going to continue for a while. Remember that mental health problems co-present with physical, they come and present as physical complaints, such as depression might present as headaches or stomach aches or not having any energy. And people are more willing to talk about those physical complaints than they are the emotional or mental complaints. A lot of uncertainty. They're going to come in frustrated because things aren't being resolved. Maybe their medical condition is not being resolved like they would like. They may be talking about just being lonely, how good it is just to get out, even to come to a doctor's appointment or to come in. They may come in expressing a lot of anger, just anger in general. They may just come in feeling angry. They may express a lot of boredom, how boring it is to be told they have to stay at home, and just being ambivalent about, well, maybe I need something. Well, maybe I'm okay. Well, and just ambivalence about whether to change anything. Again, the increase in alcohol and drug use, anxiety, depression. And also the symptoms of PTSD, I said that they could be triggered. And this is due a lot to the fears created from watching too much news. And, people a lot of times get so hung up in the news, and they'll watch it 24/7, and they will not get away from the news. And so we're going to talk a little bit about what do we tell the patients when they're expressing this. Also, for helping professionals, you have this coming in, people feeling unsupported. When people are coming in and expressing all this, everybody's so busy, it's even difficult to get support from the rest of the clinic staff or from management or whoever. Also, feeling overworked. Those of you that have been doing telehealth for mental health or for medical, there's this term called, and you may have already heard it, Zoom fatigue. People are realizing that it's more draining to do a telehealth session, and some people like me who will do an hour or 2 hours of a session with a client or a group of clients. Everybody's talking about how usually it's energizing to do a session or do a group, and now after it's over, they're feeling so fatigued because of having to watch everything so much more closely. Part of that, I also think, is staring at a computer screen for that long without a break. So that's something to be aware of, and how can you, and to have ways to manage that. Of course, we've heard of the shortage of supplies everywhere, being short-staffed, not having enough relief, and just personal health concerns. Am I going to catch COVID? Am I going to be sent home? Am I going to be put in the hospital myself and see this? And am I going to take it home to my family? These are all concerns with the medical profession and the mental health profession that has continued to see people face to face. Fear, just general fear around the whole pandemic. And it's difficult to see the personal needs at home. Even going to the grocery store, if you are, for a lot of people who are working in a hospital setting, they're working longer shifts. Maybe they have to take care of an elderly parent or something like that. When do they get the time to go to the grocery store for them, or take things to them, or even go see their kids? And not having the time to just de-stress from all of this that's going on. So I wanted to just talk a little bit about compassion fatigue and burnout, primary and secondary traumatic stress. And compassion fatigue, what we call vicarious trauma or secondary trauma sometimes, is basically because we care so much and we give so much of ourselves that it is a major emotional strain. And working with people who are talking about the trauma that they're experiencing. And this is different from burnout, because burnout is the emotional exhaustion caused by stress. It is not trauma related. But when you are dealing with people that come in and they're talking about the trauma of COVID-19, or they're talking about different traumatic things, you listen to this, and if you don't have a time to debrief, to de-stress from this, it builds up. And so we know that primary stress is when there's a direct exposure to a traumatic event, or an ongoing exposure to traumatic events. And when we look at compassion fatigue, again, it's an emotional exhaustion. And it's when someone starts losing that capacity to empathize or to have compassion. And some of the symptoms include beginning to feel isolated, developing anxiety, maybe even sometimes just dissociating, taking a mental break in the middle of something, having physical ailments, sleep disturbances. And it's because we care so much and we give so much of ourselves, but then we fail to re-energize, to fill that void. And sometimes this is referred to as STS, or secondary traumatic stress. So when we look at secondary trauma, this can occur when a person is exposed to people who have been traumatized, or they give you disturbing descriptions of trauma in an event. Even this can be if you deal with domestic violence. Even if people watch the stuff on TV on, and all the violence going on, then they're talking about it, and we can develop that secondary trauma. And the symptoms are very similar to PTSD. So this secondary trauma, or sometimes called compassion fatigue, emotionally starting to feel numb, overwhelmed, physically low energy or fatigued, professionally not performing as well on the job, not seeing to responsibilities, the morale goes down, and cognitively may feel confusion, decreased concentration, difficulty in making decisions, experiencing traumatic imagery, seeing it over and over again, reliving it in our heads, spiritual questioning the meaning of life, even lacking self-satisfaction, and interpersonally starting to withdraw from people, becoming emotionally unavailable to coworkers, to family, to friends. So how do we manage this as a professional? Well, one thing, we have to practice our own self-care. We've got to practice what we preach. Doing regular exercise, eating a healthy diet, getting enough sleep, doing yoga, learning or doing what we already know how to do with meditation. Take time away from what is causing the stress. And a lot of that goes into telling people what you need, asking for what you need. And, you know, sometimes you just need to say, I need to go take a break for 5 minutes. I need to go take some deep breaths, and tell people what you need. Spending time away, spending time with family and friends, doing something fun. And to realize this goes beyond just being stressed. This is, if you need counseling, go to counseling, but it takes time to heal. So these are some other signs of stress behavior: increase or decrease in energy, increase in substance use, including increase in tobacco use or vaping. And this is one thing they're talking about with COVID, that people that use tobacco products or vape have a higher risk of catching COVID-19. Increase in irritability, angry outbursts, trouble relaxing, crying, worrying, isolation, blaming others, all of these things that go into excessive stress reaction. Some of the physical signs of stress, and this is where you may see clients or patients come in with stomach aches or diarrhea, headaches, body pains, loss of appetite or eating too much, sweats and chills, tremors, muscle twitches, easily startled. And gee, does this sound a little bit like COVID symptoms? And so I really liked what Dr. Mehra said about, don't just say, oh, you don't have COVID and send them home. What's underneath it? And sometimes it can be that they're just so stressed they're experiencing these things. The emotional signs, we've already gone through a lot of that, that we just talked about: the anxiety, the depression, feeling guilty, lack of caring about anything, and just overwhelmed by sadness. The mental stress, they not remembering things, confusion, losing the ability to think clearly, losing concentration. If you find yourself having difficulty making decisions on the job, just simple decisions that usually just come naturally, that may be a sign that you're really suffering from too much stress. So with with how to take care of yourself as a professional, debriefing. Just take a few minutes when you've had a really difficult patient, take a couple of minutes to talk over with someone and say, I just need to say this so I can get it out, and just talk about it for a minute. And find someone that you can pull aside for a minute and say, I just need to say this. Finding that balance between work and life, that's so important. Making time to unwind, admitting and recognizing that you're having these feelings instead of trying to push it down, trying to deny that it's happening. Admit that it's happening. Admit to yourself and someone else that this is happening and that it's normal, and that it's not that there's something wrong with you. This is a normal reaction. And again, ask for what you need from coworkers, from family, from friends. And just a list of things that we can tell clients or patients. Find a good source of news. Don't look at all of the news. Don't believe everything you read. Limit the time you spend, maybe an hour a day, and that's it. And do it from a reliable source. Don't just start believing everything you see. Encourage them to ask questions. If they don't understand something they see, or if they question is something really true, ask questions and have written information available for them. I've got some resources at the end of this for you, and I'm hoping that you were sent the information. If not, they'll get it out to you. But pulling some of those fact sheets off of CDC, off of some of the websites that I've given you information for, and give them reliable information, and encourage them to stay connected with their friends and family through telephone, email, text, social media, using Skype, using Zoom, FaceTime, whatever they can use. And really important, if they already have a mental health condition, make sure that they're continuing to stay on their meds and that they're taking them like they're supposed to decrease these symptoms. I've got just one more slide. Am I okay on time, Brian? Okay. Take time to relax, to meditate, to pray, laugh. Laughing is so important. Laughing is so healing. Taking those deep breaths and stretching, just stand up and stretch. And stretching releases all of that tension. And pace yourself. Don't think, slow down, pace yourself. Don't think you have to do everything this minute. Talk about how you're feeling. Thinking positive. Always thinking positive. What are the positive things that are coming out of this? And having gratitude, always. I ask myself often, what am I grateful for today? Asking a patient, what are you grateful for today? Encourage journaling with the people that you see, and see traditional spirituality services. Seek traditional spirituality services. Diet, eat healthy, drink a lot of fluids, avoid alcohol, caffeine, tobacco products, illicit drugs, vaping, get enough rest, again, exercising. Do something that you enjoy doing, not what somebody else tells you, but an exercise that you enjoy, and finding those healthy activities as opposed to sitting in front of the TV playing video games 10 hours a day. And as much as possible, keep a normal routine to keep those circadian rhythms in what they need to be. This is the list of resources that I have found for you. And you should be able to, when you get the, if you get the slides, I think you'll have a PDF, so you can type in these or copy and paste them into your search engine and find these resources. And you can, many of them have, like the American Addiction Centers have fact sheets. The Native Center for American Indian Health has some wonderful fact sheets that you can hand out to your patients or your clients. So these are some great resources for you. And that's what I have for you. Questions or comments?
Thank you, Dr. Patterson.
You're welcome.
Does anybody have any questions for any of the presenters today? Okay. Emily, do you want to post the, there you go. If you look in the chat, there's the SurveyMonkey survey link. If you click on that and fill it out, that would be much appreciated. That helps us plan the future echoes. So if there's no questions, great presentations, everybody. We can go ahead and end.
Have a good weekend.
Thank you. Have a good weekend.
Bye.
I thank you.